We'll begin. Good afternoon, and welcome to the Subcommittee on Health hearing on achieving health equity for minority veterans. In the next 25 years, America will be a majority-minority country. Today, minorities disproportionately serve in the U.S. military. As America changes, so too will the veteran population. So must the institution that provides their health care, the types of services, the competencies it develops, and the manner of outreach it conducts must meet the unique needs of its patients. To better meet new needs, VA must address current struggles from implicit bias in medical providers and frontline staff to incomplete and missing data. VA should be the leader in American healthcare that can dynamically meet the needs of an increasing diverse and intersectional patient population. The GAO report from December 2019 found VA's Health Equity Action Plan, originally drafted in 2014 and reissued again in 2018, had no measurable outcomes to date. No one is accountable for the success or failure of its efforts. And to make matters more concerning, VA's data on race and ethnicity is inconsistent, if not altogether missing. Last month, I traveled to Cheyenne River and Standing Rock Indian reservations, where I heard numerous concerns from veterans of cultural insensitivity and racial bias perpetrated by VA patients and staff. At last week's joint hearing, we heard how women's experiences with VA can have a deeply discouraging impact on their willingness to continue to receive care at the VA. And as this committee knows all too well, no veteran is immune from harassment or assault inside facilities. We know racial bias in healthcare contributes to different outcomes and increased fatalities. Providers with unconscious or conscious stereotypes about minorities may contribute to how they respond to a patient's concern. We know the legacies of horrors such as Tuskegee experiments and the forced sterilization of Native women compounded with experiences of racial bias and culturally insensitive providers contribute greatly to mistrust of health systems by people of color. Ms. Williams highlighted in her written testimony during focus groups, participants reported that VA providers take the pain and symptoms of people of color, particularly women, less seriously than those of their white counterparts, providing a barrier to correct health diagnosis and contributing to a lack of trust. It is the undoing of bias and the building of trust that VA must work towards. VA's patients are only becoming more female and more ethnically and racially diverse. The realignment of a system built to serve white, straight men has to be a priority, from a matter of patient safety to customer satisfaction. VA should be the leader in closing the chasm between minority and white health status in the United States. So with that, I'd like to recognize Dr. Dunn for 5 minutes for any opening remarks he may wish to make.
Thank you, Chairwoman Brownlee, and thank our witnesses for spending time with us today. It's a pleasure to be back here in the committee room with you again this year. As the veteran population continues to diversify, we must ensure that the Department of Veterans Affairs is equipped to provide all those who have bravely served our great nation with equitable, high-quality health care. Last year, this subcommittee held a hearing to discuss how the VA is caring for a growing number of women who are seeking VA care, and today we're discussing how the VA is caring for a growing number of veterans who are members of racial and ethnic minorities. By 2040, military veterans are expected to be majority minorities in the country. Concerns about the disparities in health care for minorities have long existed. It's not unique to the VA either. I will note that the VA's Office of Health Equity received increased funding and staff allocations in 2019 to support its important mission of identifying and eliminating inequities in care for minority veterans. The office's work culminated last fiscal year in the release of a new version of its Health Equity Action Plan. I look forward to hearing this afternoon about how the VA is going to track the progress in implementation of that plan and what metrics they plan to assess. I think all of us, the VA, Congress, veterans themselves, all want to ensure that every single one of the brave men and women who served our country and worn its uniform are well taken care of. Service and patriotism know no race or gender. I'm grateful to the witnesses and audience members for being here today. I look forward to a productive conversation. And I will apologize to the chairwoman in advance that I must leave early. However, it is in the service of veterans. We have a veteran STEM bill that's being signed into law this afternoon, and so I'm going to be attending that ceremony. And with that, I yield back.
Thank you, Dr. Dunn. We have one panel today. With us is Dr. Carolyn Clancy. She is the Deputy Undersecretary for Discovery, Education, and Affiliate Networks at the Veterans Health Administration. She is accompanied by Dr. Ernest Moy, the Executive Director of Health Equity, and Dr. Donna Washington, an attending physician at the Greater Los Angeles Health System. Then we also have Ms. Kayla Williams. She is a Senior Fellow in Military Veterans and Society Program Director at the Center for a New American Security. And last but certainly not least, Ms. Melissa Bryant, the Legislative Director for the American Legion. So welcome all of you. Thank you for being here. And with that, I recognize Dr. Clancy.
Good afternoon, Chairwoman Brownlee, Ranking Member Dunn, and distinguished members of the subcommittee. I appreciate the opportunity to discuss our continued progress in achieving health equity for minority veterans. I'm accompanied today by Dr. Ernest Moy, the Executive Director of the Office of Health Equity, and Dr. Donna Washington, attending physician and researcher at the Greater Los Angeles Healthcare System. Our goal at VA is to shorten the distance veterans need to go for care and to leave no one behind. Health equity means that all veterans receive timely access to safe, high-quality care that helps them achieve their highest level of health, regardless of age, gender, race, ethnicity, sexual orientation, and geography. Overall, there are few differences in the quality of services delivered by to veterans by VHA related to race and ethnicity. Preventive care and care for chronic diseases are delivered similarly for all groups within VHA, in contrast to the private sector where systematic disparities are too common. While the delivery of services is equitable, outcomes of care for racial and ethnic minority veterans in our system often lag behind outcomes achieved by non-Hispanic white veterans. For example, despite receiving comparable services, racial and ethnic minority veterans with diabetes are more likely to have poor glucose control and less likely to have good control of blood pressure and cholesterol. There are also interactions between gender, race, and ethnicity in these outcomes. For example, non-Hispanic black veterans with diabetes are less likely than non-Hispanic white veterans to have good blood pressure and glucose control, regardless of sex. Among veterans with heart disease, women, regardless of their demographic background, are less likely to have good cholesterol control compared with either non-Hispanic black or white men. In comparison to commercial plans, achievement of control of these cardiovascular risk factors are much better in VA, but we're not done yet. Health equity also includes factors outside the direct provision of care that impact patient outcomes, including individuals' education, income, geography, and other factors. The Office of Health Equity has a broad charge, including analyzing data on disparities, raising awareness about veterans' equity issues, working with our medical centers to improve outcomes for all veterans, and supporting workforce diversity and inclusion within VHA. We have successfully addressed what are often referred to as the social determinants of health on a large scale, for example, reducing homelessness and food insecurity among veterans. And we also, unlike most healthcare systems, have the capacity to address other determinants such as education, employment, and social isolation in conjunction with the Benefits Administration and Veteran Service Organization and others. Consequently, the office has supported the development of two unique tools. One allows our medical centers to identify and address social and social determinants in their particular populations. A second actually is an equity-guided improvement strategy, which uses equity information at VA medical centers to identify specific groups of veterans at a higher risk of receiving lower quality of care. In the December 19 GAO report, there was a recommendation that the office develop performance measures and clear lines of accountability to track progress towards equity for veterans and to assess and improve the accuracy of racial and ethnic coding in VA systems. In response to the first, the office, along with the Health Equity Coalition, which is comprised of leaders across the Department of Veterans Affairs, have updated the Health Equity Action Plan, laying out a roadmap for the future. In response to the second recommendation, the office is partnering with researchers and supporting two assessments. The first, led by Dr. Washington, will formally determine the quality of coding by comparing existing racial and ethnic coding in the electronic record with self-reported survey information, because that is, the self-report is considered the gold standard. A second assessment will collect race and ethnicity information in VA medical centers directly from veterans using an iPad, which will minimize staff discomfort when asking for this information, particularly in a situation where there's a lot of people around. It's worth noting that race and ethnicity data are missing on about 7% of our veterans, which is better than that seen typically in the private sector. We're also proud to report our progress in fostering a more inclusive patient experience for women and LGBT communities. The office works with our Office of Women's Health Services to support assessments of equity issues faced by women veterans and share data. I think you've heard about the research we're supporting that involves close collaboration between researchers, providers, and the women patients themselves. The office also works with LGBTQ coordinators to support assessments of equity issues by these veterans. The office has also served as VA's point of contact with the Healthcare Equality Index, a major benchmarking tool throughout the healthcare industry, and is sponsoring work with the CDC to examine LGBT veterans because they cannot be systematically identified in our current data systems. It is our expectation that it will be possible once Cerner is implemented to capture that information systematically. Our goal is to meet veterans where they live and work, so we can work with them to ensure they achieve their goals by teaching them skills, connecting them to resources, and providing the care they need along the way. We're committed to advancing our outreach and empowerment to further restore the trust of veterans every day and continue to improve access to care. We agree with the chairwoman's statement that VA should lead in this area, and that is exactly our aspiration. Our goal is to give our nation's veterans the top quality experience and care that they have earned and deserve. We appreciate this committee's continued support as we identify challenges and find new ways to care for our veterans, and look forward to your questions.
Thank you very much. And I now recognize Ms. Williams for 5 minutes.
Chairwoman Brownlee, Ranking Member Dunn, distinguished members of the subcommittee, thank you so much for this opportunity to discuss this underexplored topic. Overall, I fully agree that VA is an excellent source of health care, boasting low wait times, high quality, military cultural competence, and low cost. However, not all groups of veterans find VA to be equally welcoming, accessible, or adequate. My testimony is drawn primarily from the forthcoming CNAS report, New York State Minority Veteran Needs Assessment, supported by the New York State Health Foundation. Given the time limit, today I will focus my spoken remarks on racial ethnic minority and LGBT veterans. As mentioned, racial minorities experience bias in healthcare that can and does lead to worse outcomes, such as the higher maternal mortality rates among African American and American Indian and Alaskan Native women. Racial bias in healthcare causes preventable deaths. Stereotypes about minority individuals' pain tolerance and symptoms have been reported to influence medical providers into disregarding complaints by minority patients, and CNAS focus group participants expressed beliefs that these challenges extend into the VA system. Some reported that VA medical providers take the pain and symptoms of people of color, particularly women, less seriously than those of their white counterparts, creating a barrier to correct diagnoses and contributing to a lack of trust. Advocates for minority veterans also argued that VA providers are inadequately culturally knowledgeable, negatively affecting the provision of care. For example, a number of participants emphasized the need for providers to understand a lower willingness in the African American community to seek out mental health care. One participant said, "In Black culture, there isn't a lot of tendency to seek help for mental incapacity. You can't just have a doctor say, 'Here's a service, come and get treatment.' If they, at VA, understood the cultural aspects, they have to understand, talking to a person, that there's a reason they're not accessing services." Implicit and explicit biases of healthcare providers negatively affect minority veterans. Participants felt that they received substandard treatment by doctors. LGBT veterans also face barriers in accessing VA healthcare, including staff with inadequate knowledge and openly hostile fellow patients. This is particularly concerning, given that a higher percentage of gay service members suffer from PTSD and other mental health conditions. Importantly, while LGBT status is not causal for PTSD or suicide, it is a risk factor. Stigma, prejudice, and discrimination create a hostile and stressful social environment that causes mental health problems, a phenomenon known as minority stress. Gender confirmation surgery is specifically excluded from the VA medical benefits package. This is not in alignment with accepted standards of care for gender dysphoria. Because VA healthcare is minimum essential coverage under the Affordable Care Act, veterans who are enrolled in VA healthcare do not qualify for subsidies in the health insurance marketplace. Accordingly, these veterans may be unable to enroll in a plan that would provide this medically necessary care. Crucially, there are dramatic reductions in suicide among transgender individuals who receive appropriate transition-related care. Denying it violates VA's stated commitment to suicide prevention. Additionally, VA does not provide IVF for same-sex couples, another discriminatory practice that should be eliminated. VA should work to become more welcoming for all minority veterans by implementing trauma-informed and dignity-affirming care, including effective cultural awareness training for employees, updating waiting room reading material, posters, and television channel default settings to be more inclusive, increasing Veterans Experience Office efforts to alleviate disparities in the experiences of minority veterans, expanding the nascent End Harassment campaign to include the harassment of LGBT and racial ethnic minority veterans, and replicating VA's existing secret shopper model of ensuring that frontline staff members are aware of resources for MST survivors to also include minority veteran coordinators and LGBT veteran care coordinators at VA medical centers nationwide. Additionally, VA should carefully review all policies and provisions of the medical benefits package to eliminate those that discriminate against women and LGBT individuals. Should VA be unwilling or unable to take these actions independently, I urge Congress to pass legislation requiring VA to cover gender confirmation surgery and IVF for same-sex couples. VA is a top-tier provider of health care. Identifying and eliminating any barriers that make it less welcoming and effective for the rapidly growing population of minority veterans is an important part of ensuring health equity for all who have served our great nation. Thank you, and I look forward to any questions you may have.
Staff Sergeant Herman A. Day fought in the Italian campaign of World War II. He was assigned to the 92nd Infantry, the Buffalo Soldiers, the Colored Division. Reports at the time cited poor combat performance, low morale, and malingering. The 92nd Infantry Division was considered of inferior quality by both German and U.S. commands. Many historians have begun to reevaluate the combat record of the 92nd Division as concurrent reports of its honorable performance have continued to surface. Numerous veterans of the division believe that the reports of poor performance were motivated by racist sentiments present within the senior officer ranks. To wit, the 92nd Division commander asked the Army, or advised the Army rather, against ever again using African American soldiers as combat troops. Even as evidence mounts in support of the division's honorable conduct, some still seek to suppress these facts. Staff Sergeant Herman A. Day was killed in action in Italy 75 years ago on February 10th, 1945. He was my grandfather. I never had the opportunity to ask him about the racial prejudices he faced during his service, but it is well documented what he endured. Despite presidential executive order to desegregate the armed forces in 1948, the stain on the U.S. military history lives on and reflects the racial and ethnic biases many minorities still face when using the Veterans Health Administration services, hence why I share this personal story. Chairwoman Brownlee, Ranking Member Dunn, and distinguished members of who serve on the subcommittee, on behalf of our National Commander, James W. Bill Oxford, we thank you for the opportunity to discuss the topic of how VA addresses health inequities for minorities across the Veterans Health Administration. I proudly represent the American Legion and appreciate the opportunity to assist the subcommittee in better understanding this critical topic. We must ensure that the institutions we built to care for our nation's veterans give every veteran, regardless of gender, race, sexual orientation, or creed, the quality of care and support that they deserve. Why? Because recent studies show that racial and ethnic minority veterans represent nearly 22% of the total veteran population. VA projects that the minority population will continue to rise over the next few decades and reach an estimated 35% of the total veteran population by 2040. Often the only woman of color officer in my units, I can point to many occasions where I have helped soldiers who came to me for advice, counsel, or reporting of incidents dealing with racial, gendered, sexual orientation discrimination, harassment, or even assault within the ranks. My service was also during the time of Don't Ask, Don't Tell, where I had the truly unfortunate duty of separating troops from service due to their sexual orientation. This is relevant because depending on discharge status, LGBT veterans would not have the same access to veteran benefits, adding an overall distrust of the military and veteran healthcare systems. Notably, the American Legion is the only veteran service organization that assists veterans with discharge upgrades and represents them before service discharge upgrade boards and hearings. Many clinical outcomes have significant racial gaps in data collected for conditions such as hypertension, cardiovascular events, diabetes, and labor and delivery. A grim example of disparity in healthcare outcomes is due to racial bias is in the nationwide maternal mortality rate in minority women, who are 2 to 3 times more likely to die from pregnancy-related causes than white women. A widely publicized U.S. Supreme Court petition last year unsuccessfully challenged the Fearless Doctrine, Daniel v. United States, where which involved the death of a Navy nurse who died in childbirth in the same labor and delivery ward in which she served at Bremerton Naval Base. This is a chilling example of where the deceased was also a racial minority. Her pain was ignored. And it shows how this nationwide trend can be reflected in the military and in our veterans, and may color the perception of disparate care provided to minority women by both military and veteran medical centers. I should also note that the petitioner in this case, the lawyer Walter Daniel, is my classmate and friend of over 20 years. It becomes necessary to ask why these care inequities exist in the microcosm that is our community, and research to what extent these disparities are attributable to negative outcomes. Chairwoman Brownlee, Ranking Member Dunn, and distinguished members who proudly serve in the subcommittee, the American Legion thanks you for the opportunity to illuminate the positions of the nearly 2 million veterans of this organization. It is a priority of the American Legion that all of our nation's veterans receive the same quality of care and support we expect from the VA. By action of this committee, we can see that it is a priority for you as well. As we unpack the myriad reasons why minority veterans on the whole report either negative healthcare outcomes or unequal treatment under the law at the VA, the American Legion stands ready to support this subcommittee with observations and expertise. Thank you.
Thank you, Ms. Bryant, and thank you for sharing your story and your grandfather's story with us here today. I appreciate it. I'll now recognize myself for 5 minutes. The first question that I had, I want to go to the application for health benefits, which I think is probably maybe one of the VA's first touches, on a VA. And the application asks, for a lot of information, sex, gender identity, and so forth. And reading through this, in question box number 4, it says, are you Spanish, Hispanic, or Latino? And so I'm just wondering if Spanish, is that a mistake? I don't think Spanish is an ethnicity. I don't think the U.S. Census Bureau uses it as an ethnicity, OMB. Is that a mistake, or?
I'll have to take that for the record. I would point out that about 2/3 of people who sign up for our healthcare system are actually signing up in person and are probably being asked that question verbally, but I will check on that. I had not actually seen that application. Thank you.
Okay, and well, let me just point out a couple of other things that you can take back. One is when asking race, there's a box for American Indian or Alaska Native, but they don't ask for the tribe, which is an important a piece of information. Nowhere on the form does it talk about the language needed to use with either the veteran or the veteran's family. We've heard many stories of particularly our Native veterans who, go back to their land and speak their language, and as they grow older, they haven't spoken English in a very long time, and that becomes a barrier to their health care. So I think that would be a good question to ask. And then also on the back of the form, it also asks if you're eligible for Medicaid. It does not ask the question if you are eligible for Indian Health Services, which I think is an important piece of information to have. It's having just traveled to Indian country, it's very clear that the VA doesn't have a good handle on our Native veterans and where they're getting their health care, whether it's the VA or Indian Health Services or a combination of both. The counts are very difficult to attain. So if you could take that back, because I feel like, as you said, when they first sign up, this is probably something that they're asked, but this is certainly an important touch point, and I just think that there's more information that needs to be included. So I wanted to ask you, Dr. Clancy, also, you mentioned in your testimony that the VA collects the Survey of Healthcare Experiences of Patients, which is the VA's sort of national standardized, publicly reported patient survey. But it goes on to say that we don't really collect the racial and ethnic groups because the number of minority veterans responding to this survey is too small. So is that an accurate statement?
So there are two sources of information that we get from veterans on the outpatient basis. One is the survey you just referenced. The other is real-time information where veterans can go to a kiosk in any of our facilities and report on their experience that day. And we think that that's, it's called V-signals. We think that's very important in terms of service recovery and so forth. It's that survey, not the SHEP survey, which actually very few people are actually indicating their race or ethnicity. So I would think that as we look into sources of missing data, we might be able to pick that back up. But this is like real-time, very short surveys that are now being deployed at all our facilities.
And do they ask ethnicity and gender and?
They do, but I don't believe that many people fill it out. So we have some work to do there.
Well, it just seems to me in terms of the survey, I think that, if we don't have many minority veterans filling out the survey and or putting that data on
Right.
site, I wonder what the problem is and why that is. And I just feel like it's something that we should, if that's an issue where we can't collect the data, what are we going to do? What are we going to do to make sure that we do collect the data? Because the data, is really the starting point in terms of providing high-quality health care to each and every one of our veterans, particularly our minority veterans. So, do you have an answer for that, or?
No, but I will get back to you with a more
Okay.
thorough answer. This is relatively new information, but it's especially important because it actually gets at a dimension that the SHEP surveys don't, because it actually gets more at veteran trust in our system and in the department, which is hugely important to healthcare outcomes. So we will get back to you.
Okay. And have I run out of time? I have run out of time. So I will yield back and yield to Ranking Member Dunn.
Thank you very much, Madam Chair. I'll direct my first question to Dr. Washington, if I may. You know, we've read that minority vets are less likely to be treated for hepatitis C, even though they I mean, with the same instance. So why do you think that is, and what are we doing to try to correct that?
I'm
I
sorry.
guess I directed the question to Washington, thinking you're the attending physician on the wards, right? Hit your microphone.
Thanks for that question. I am the attending physician. That is correct. So your question is, why are minority veterans less likely to be treated for hepatitis C?
And I assume that's, you know, per capita, sorry, about 100 cases, minority treatment get treatment less often. Why would that be?
That's a really excellent question. I actually do not have the answer for that. I do know certainly that is the case, that minority veterans are more likely to have hepatitis C, that though they have very high treatment rates in comparison to treatment rates outside of the VA, that there are definitely racial ethnic differences, as you mentioned, within the VA.
Do you have any eyes on that, Dr. Moy? Any insights?
I don't have anything to add to that.
Dr. Clancy?
No, except to note that at one point we were doing special outreach to Hispanics with Hep C for treatment because we were very concerned that we were missing them. I will say that for every facility in our system, every facility got a list of the veterans who were Hep C positive so that they could do outreach. I have not seen it stratified by minority status, but would be happy to look into that.
Also, Dr. Clancy, you know, when these new Hep C treatments, and there are a number of them, started becoming available some 5 or 6 years ago, what steps did the VA take to include those in the treatment for minorities and, in fact, all of your population? You had to be progressive. It was expensive, but what would you?
Well, it was expensive, and it was so expensive we had to come back to the Congress to say we actually need more resources, and the Congress was swiftly responsive, for which we were very, very appreciative. So fast forward several years, we have cured 100,000 veterans of hepatitis C, which I don't think any healthcare system can claim. I simply have not seen the data in terms
Stratify.
of...
Do you have a sense of how many are untreated?
I believe that we have reached the vast majority of people who are eligible for treatment. So that brings up the question, what do I mean eligible for treatment? People who do not have ongoing substance use or other disorders that would make treatment a bit risky for them, or people who don't actually refuse to be treated. But we have been able to reach a very high proportion of the veterans with Hep C.
That's a counseling problem. Dr. Moy, let me ask you a question here. Do the patient satisfaction rates vary between minority veterans and white veterans?
Yes, they do. So, and the SHEP surveys do indicate that minorities tend to be less satisfied with the patient-provider communication than.
Can you quantify that?
Yes, we can quantify it. Actually, Dr. Washington is our expert
Okay.
on the SHEP by race ethnicity.
Great. Dr. Washington.
I am regretting that I did not bring those exact numbers with me. We can certainly get back to you with the
I'd
exact
like
numbers.
to, but do you have a ballpark?
I will have to look
Okay,
at my numbers.
we're going to hold
I
you
don't
to it,
want
though. I want to see those numbers.
misspeak.
How about the cost? Can you compare the cost of treating minority veterans with the cost of treating non-minority?
We did not look at cost in our analyses.
That might, Dr. Clancy, would you speculate on that? Does that have any bearing on the rate of treatment, or?
Well, cost is important, but as a system with more or less a global budget, right, we're sort of simulating what things would cost. The biggest issue of concern to us is are people not getting treatments because we didn't try hard enough, because they didn't trust us when we spoke to them and said, we're recommending that you get treated with this regimen or medication or whatever it is. In general, I think the larger concern in the field of health equity is that, in fact, it costs less because of the factors I just mentioned.
Yeah, curing the disease is generally
Yes.
cheaper than treating it chronically.
Yes.
So you don't see any deliberate attempt to not treat minorities given cost. Is that fair to say?
Yes.
Okay. With that, I yield back. Thank you.
Thank you, Dr. Dunn. And Mr. Cisneros, you have five minutes for questioning.
Thank you, Madam Chairwoman, and thank you all for being here today. Dr. Clancy, the Health Equity Committee, created in 2012 and chaired by the Director of the Office of Health Equity, was created as a steering committee dedicated to minority veteran health issues, amongst others, in order to oversee timely completion of initiatives and ensure the commitment of appropriate organizational resources. However, between the years of 2015 and 2019, that committee did not meet on a regular basis. So how can it provide adequate oversight of the VA's minority veteran health initiatives if it doesn't meet for 4 years?
I think it's fair to say that with new leadership in place, that we have a reason to have much, much higher expectations. I think that would be the easiest way to respond to your question. You're absolutely right. If the committee doesn't meet, how can they possibly do anything? Under current leadership for VHA with Dr. Stone, where he is putting a very, very high premium on consistency across our system. Not good for this state compared to others, but good for all veterans, regardless of where you get your care. That sometimes is called highly reliable care. We now have a framework to actually move forward and make sure that disparities and tracking that in performance are routinely included.
So when's the next meeting scheduled to meet? When's that committee scheduled to meet?
Dr. Moy?
March 2nd.
March 2nd? And are they going to meet on a regular basis now, or how often will they meet?
Yeah, we've been meeting monthly for about the last year, and then we're just tapering down to every 6 weeks because we have finished our Health Equity Action Plan update as well as our operational plans for this fiscal year.
Okay. So in 2014, OHE identified activities to make improvements in 5 focus areas, but VA couldn't track progress because there were no performance measures and are no clear lines of accountability for offices. How can we track improvement and track performance if we don't create any performance measures? Has that changed?
Yes, and so with the guidance of the Health Equity Coalition, we've created a 5-year Health Equity Action Plan that was endorsed by our Undersecretary this past fall, and we just finished creating our fiscal year 2020 operational plan. The Health Equity Coalition at the end of our fiscal year will compare what we said that we would do with what we actually did. And so I think we are highly accountable at this point.
All right, can you share that with us?
Yes,
Share
it's
that
on our
with the
website,
committee?
but yes,
All
we'll
right.
be glad to do that.
And I would just add that it's under Dr. Moy's leadership that really we've got facility-specific information routinely provided, and I think that's a very key picture, right? Because if you're just looking at a global national report, we all know the response to that is, we're doing great, but it must be those other people, right? When it's about where you provide care, it has a very different implication.
So according to the December 2019 GAO report, the VA cannot ensure the accuracy of race and ethnicity information labeled in the electronic health records. Dr. Clancy, how has this impacted the VA's ability to gather retrospective data in order to measure the effectiveness of minority health care?
So I'm going to turn to Dr. Washington, who's going to be helping us a lot with this as we try to make improvements.
Thanks for that question. So we have a study underway, the study to which Dr. Clancy referred to in response to the GAO report, that is looking to exactly quantify what that rate of missing data is as well as inaccurate data. And we will be retrospectively reevaluating some of our measures of differences by race and ethnicity to look at the impact of those inconsistencies in race and ethnicity data coding.
Will you be asking individuals to self-identify so we can get?
So actually, the Survey of Healthcare Experiences of Patients does ask individuals to self-identify. And so we'll be using several years of that data as sort of the gold standard for race and ethnicity data, and we will be combining that with the electronic health record report of race and ethnicity so that we can see not only what the overall national inaccuracies are, but we'll be able to hone in at the healthcare system level so that we can identify if there are particular areas or particular sites in which we need to look more closely at the practices.
All right, with that, I yield back my time.
Neros, I now, recognize Mr. Rose for 5 minutes.
Thank you, Madam Chairwoman. Ms. Williams, thank you for looking at this New York State assessment. If you were crowned Empress of New York for a day, give me 2 or 3 things that you think New York needs to change as quickly as possible as it pertains to this issue?
Among the things that I think are most important to realize are that veterans do not leave the military and go and live in veteran bubbles. We don't live in veteran barracks and work in veteran employment situations only. So all of the situations that can be challenging for minorities in the broader community also affect veterans who happen to be minorities. So I think it's imperative at the state level, given the current national situation, to carefully seek to identify any laws or policies that are going to be disproportionately affecting minorities at the federal level and do what they can at the state level to address those. So for example, New York already provides some protections for LGBT folks that are not available at the national level. So seeking out additional areas like that I think is incredibly important.
What do you think that the VA should be doing in New York?
I think VA nationally should address the inequities already identified, such as the lack of provision of gender confirmation surgery. There are also some disproportionate challenges for women, such as the fact that women vets can be charged co-payments for birth control in VA, which cannot happen in.
Are there any ways that VA looks worse than the rest of, in New York, it looks worse than the rest of the country?
Unfortunately, we're not able to assess that on the health level, and that's the primary area that VA is able to provide care. We're really excited to hear that VA is releasing a report soon. I think that's going to be really exciting, beneficial for all of us. I also do want to give one quick shout out to VA on other areas. This is broader than New York, but there are some areas of real strength. For example, the Minority Veterans Program, which is collecting genetic data from veterans, is doing some really groundbreaking research that is also beneficial in this area. They recently released, for example, a report on levels of anxiety and identified genetic loci that are different between African American and white veterans. So VA is doing some great things, and I want us to continue to support and encourage that across the board in New York and nationally. I'm sorry, that is what I meant. Yes. Thank you very much, Melissa. You're welcome. Long week.
Sure.
Million veteran program. Thank you.
Thanks. One thing that I've noticed in New York and around the rest of the country is that while indeed, GWAT vets look like the country and the beautiful cultural mosaic that it is, but our Vietnam vets and Korean War vets of color experience particular trauma. Fighting for freedom abroad, not exactly finding that same freedom here at home. In your analyses, what particular challenges have you seen for veterans of color who are older from those earlier conflicts?
When we did a focus group in northwestern New York, we definitely encountered older veterans of color who were struggling with serious economic problems that are, again, related to the economic conditions in the region. And some of the federal level protections that try to help with that, so federal hiring preferences, for example, are less relevant to those veterans because there aren't very many federal jobs there. And so finding ways that we can improve the economic outcomes of minority veterans in in upstate New York, where, you know, things are not as vibrant economically as, say, in the city, I think is really incredibly important, especially as they're reaching, you know, in some cases, the end of their earning years and are going to be looking at ways to manage moving forward. So that definitely is something that's a challenge, although, of course, that population does tend to be whiter. So yeah,
Sure.
the social supports are not as strong for minority veterans.
Would anyone else like to touch on
I
that
would,
point? Yeah.
please, Representative Rose. Completely concur with everything that Kayla said. And in addition to that, on the benefit side, there's impact to healthcare outcomes. So studies have historically shown that there is racial bias, implicit and bias that is injected into lower rating decisions that are given for service-connected claims. And so there's automatically, as I touched on in my opening statement, there's a distrust that follows, in particular, the African-American community, but it flows into the Hispanic community for those who are bilingual speakers. And it really does go back for the history of our country's armed forces to where that distrust lives on through generations. And so for the Vietnam era, as you articulated already, they came home to an unwelcomed environment. If you think of those who were fighting through the civil rights movement at the same time, of fighting through battles in Vietnam, when they came home, they were automatically distrustful of the VA, and that's compounded by the overall distrust of the VA by the Vietnam generation to begin with. But when they got older and they started filing their claims and they started going to claims officers, that's where we have seen at the American Legion, as reported through our System We're Saving program, as reported to our service officers who are out in the field, that there is a bias that can be injected into claims that are submitted by minorities.
Fantastic. Thank you.
Thank you, Mr. Rose. No other members are present, so I have a few more questions that I'd really like to ask. First question is, in 2016, the VA Health Equity Report, it states that most of the research on racial ethnic disparities among veterans has focused on single clinical conditions or on limited racial ethnic minority group comparisons. There's limited evidence on health and health care for racial ethnic groups of veterans other than Black and white. So, Dr. Clancy or Dr. Washington, is there more research going on, research on disparities that have occurred since then, or anything that's currently underway?
Yes, actually, there's quite a bit underway. So with respect to the single conditions, then what we have done is to systematically look at all different medical conditions, I should say diagnosed medical and mental health conditions by race and ethnicity, as well as by sex and rural residents in rural geographic areas, and have cataloged that across the VA. So that information is available in the health, in the National Veterans Health Equity Report, which is publicly available on the Office of Health Equity website. In addition, then we've looked beyond diagnoses to start looking at differences in mortality by race and ethnicity. And in fact, late last year, then we published a report that compares disparities in all-cause mortality as well as cardiovascular and cancer mortality by race and ethnicity among veterans with similar conditions in the broader U.S. population. So that information is available. We were gratified to find that many of the racial and ethnic differences present outside of the VA are either smaller or non-existent within VA.
Thank you. And, you know, I lead a women's veterans task force, and so we've been talking a lot around issues that impact women veterans and trying to find inequities and address those. One of the issues that always tends to come up is that if women are a minority, and then breaking down women, you know, African American women, LGBTQ women, Asian women, Latina women, and do you? It doesn't seem like you either have, you know, Latinas and women, but not, you can't break that out.
Well, we're starting to support more research on that, and in fact, we saw a publication just the other day, which we'll get you a copy of. And what I found striking was, while it might be plausible to imagine if you're female and you're a member of one of these other groups that would be additive, it actually was not a consistent pattern. So I think we have a lot to learn about why that is. Why is it that it would look one way for diabetes and a different way for mental health? And so forth. But I think that's why the work that Dr. Washington is going to do, helping us to make sure that the data on race and ethnicity are accurate, would be most important.
Thank you for that. And Ms. Bryant, in terms of the American Legion, do they have programs that are, reaching out to minorities that maybe we could learn from?
The American Legion does have their programs that reach out to all veterans, of course, and recognizing the intersectionality that you just mentioned, myself being one of them, being a woman of color, but there's also specific measures that we even recognize internally that we should probably look at in order to ensure that outreach is appropriate. So through all of our programs, whether it's on the economic opportunity side or on the healthcare side, through our System We're Saving program, where we ferret out information of what's happening down at the VISN and down at the medical center level, we try to find where those systemic challenges may come. 9 times out of 10, it's involved with outreach, and then what we're looking at doing is looking even within our resolution process, as we are a resolution-based organization, and what we should be doing to give greater attention to minority veterans.
Thank you for that. So, Ms. Williams, too, I am, very interested in the findings that you have shared and the focus groups that you're doing and determining things like veterans of color were taken less seriously for pain concerns than white veterans. I think this is very valuable information, and just from your vantage point, how should the VA move forward, to provide more patient-centered, competent care like that? And secondary to that question, I'd be interested if the VA is doing any kind of focus groups like Ms. Williams' organization is doing to understand some of the disparities and maybe biases and other kinds of things that exist. So, Ms. Williams.
I think VA has a great opportunity to use the existing survey data that it has to identify where there may be pockets that are particularly problematic, particular VISNs or medical centers. The Veterans Experience Office, which is also collecting a great deal of survey data, is another source that they can draw on to identify challenges and try to explore how to improve them. My experience at VA is that VA is swimming in data. The challenge is analyzing it and then figuring out how to take appropriate action. One step that I would put forward that undercuts my previous position. So when I ran the Center for Women Veterans at VA, there's a Women Veterans Program Governance Board that has all of the senior leaders across VA sit on this governance board. It is supposed to meet periodically and address cross-cutting issues, because some of these problems that we're talking about, they cross departments within the agency, right? So something can be a health issue, but also have a benefits component. So having folks from across the different business lines sitting together to tackle problems is beneficial. My belief at this point is that it should be reconfigured to be a governance board for all traditionally underserved populations, with subcommittees for women, racial ethnic minorities, LGBT veterans, MST survivors, others that may have these cross-cutting challenges, so that teams across VA can come together and identify the best way to solve the problems and communicate publicly about what they're doing to solve the problems and deal with all the nuances of the issue. Thank you.
Yep, thank you.
We'll take that back. No, I agree with you, because, I mean, one way to effectively to create a perception that maybe we're minimizing problems is to cut it into too many little pieces, and I think bringing it together, there's a lot of value in that.
Yeah.
Thanks.
But Dr. Clancy, back to the other question that I had, is the VA doing any kind of focus groups to understand what the experiences are for our minority population amongst veterans. And we can collect, I think that collecting of the data is obviously critically important. I don't want to discount that, but we could have, perfect data.
Right.
But if we're not applying what we're learning to the practice in terms of servicing our veterans, then it's really useless. Because we know with those component pieces, there are cultural competencies and other issues. So I'm just wondering if the VA does sort of take a deeper dive in looking at focus groups to help determine that.
That is, focus groups are a very consistent feature of much of the research we're doing on disparities in healthcare, and certainly a very big part of what we're doing in terms of the End Harassment campaign. One reason I'm such a fan of Dr. Washington's work with Dr. Yano, and I'm pretty sure that you have heard about this, is this notion that the research itself starts with a collaboration between researchers, providers, and patients, so that when patients do bring up issues, it is easy or relatively straightforward to say, gosh, we hadn't thought about that when we wrote this application, but that doesn't mean we can't act on it now. So to do a survey to ask how many times have you felt discriminated against or gotten some kind of communication you thought was biased, that's hugely important. The other technique that we have used in some circumstances that grew out of research but is actually part of ongoing operations is so-called standardized patients. In about 5 or 6 facilities now, veterans are given the opportunities to bring in an audio recorder to their encounters. And this is used under peer review protections, but the primary care clinicians get a lot of feedback about, did they miss cues from the patient? For example, just using Melissa's example about mental health. When you said, gosh, what you need to do is go see the mental health provider, this patient was kind of telling you that it's not that easy for me. And, it's very much a collegial kind of conversation. We've also trained actors in some settings, particularly for resource referral centers related to the homeless program, to try to find out, are there systematic issues? And interestingly, I'm sorry, Representative Rose left, older African Americans were an issue, and the program made changes to fix that.
Thank you. Thank you for that. I just think this is really important, and because I know the VA will say we've collected the data, we're doing training, but how to really really be able to sort of see in and witness in the examination room or in a mental health setting, wherever it might be, that these practices and what we're learning are actually being applied, I think is really important. And I mentioned in my opening comments that I recently visited Cheyenne River and Standing Rock. Well, I've also been to the American territories in the Pacific, and have been to Puerto Rico to look at VA health services there. And it is abundantly clear when you go to these locations that the quality of care for our veterans who have served our country is less than what we see in the continental United States. And I think some of that is definitely a cultural divide, without question. And I think we just, we need to do a deeper dive. In a day or two, we're going to have a hearing on our community care networks, and we still don't even have someone who's going to take care of Hawaii and American territories. And my first reaction to that is that should be first on the list and not last on the list, because it's where, it's hitting where the most desperate needs are. And I think the VA's got to do a better job and be more vigilant and be in sort of a a model of continuous improvement in terms of these cultural competencies, because the veteran population is changing, and I don't think that we're fully prepared. So I'm going to be anxious to see, what kind of from the data, how that data gets applied to real applications, so that our veterans are feeling welcome to the VA. All of our minority veterans, being able to, as we were talking about, crossing over, and I think Ms. Williams' idea is an excellent one, but there's a lot more work that needs to be done. And just before I close and let everybody go home, I just wanted to point out that, and I think that this is pretty alarming, but there was a recent Military Times poll that found that more than half of active duty minority service members have personally witnessed examples of white nationalism or ideological driven racism within the ranks. And I think in Ms. Bryant's written testimony confirms that we can only assume that this experience will continues on into the veteran community. This is alarming to me, as and I guess the question is, are we thinking about effective strategies for addressing this issue in the veteran space, and also what are the health impacts of experiencing white nationalism and ideological-driven racism? Ms. Williams, Dr. Clancy, Dr. Washington.
I'll just quickly dovetail on your point, ma'am, and that is, I often find myself saying this in testimony, that what happens when we're in uniform doesn't change when we come off of uniform. I can speak for myself. I can speak for being a representative of focus groups when I worked in DOD and when I worked in government capacity, where, again, that, first of all, there's an isolationism that sort of happens when you are a minority, and when you're an intersectional minority, such as I am. You're often the only one in the room, and you're the only one who's the representative for others to come to as well. And I can certainly assure that I saw tattoos, like I saw plenty of people who were affiliated with white nationalism, and it saddens me, I've been out since 2009, that it's still being reported today. And I'm glad that you raised that, because I was actually reading, as a part of my research for this testimony, a Guardian article that speaks to the same challenges in the RAF with our friends in the UK. So clearly this is a problem of racism that still persists, and I, again, without getting too emotional in my plea, I can't imagine that my late grandfather would imagine his granddaughter still talking about the same issues that he faced 75 years ago.
I think you're absolutely right. Minority stress is real. Having to endure discrimination is bad for health outcomes, and we see that white nationalism and sexism and homophobia and transphobia, they often hang together. So if we're seeing spikes in any of these, we're likely to see them in others. And that's why I recommended that the End Harassment campaign that VA has launched, which is a terrific start for dealing with sexism and gender discrimination and sexual harassment, that as more is learned about what messaging is effective, that should be expanded to also tackle racial harassment and homophobic and transphobic harassment within VA facilities as well, because it's incredibly important that the place that folks go to get health care, if nowhere else, should be a place where they are safe, they are welcomed, they are comfortable, and they do not have to endure these types of experiences. Certainly VA, unlike other sectors of care, has an obligation to care for all veterans, even those who behave inappropriately towards their fellow patients. But there are systems in place that can be used to ensure that folks who do behave inappropriately can be put into the disruptive patient behavior management system and have escorts or whatever may need to be done to ensure that those around them are able to access care safely. Thank you.
Thank you. Dr. Washington or Dr. Clancy, anything else to add?
I think it's fair to say we share your concerns, and A lot of this comes back to what kind of trust. Do veterans trust that we've got their backs, that we will provide them the appropriate care regardless of their background? And if you've had such negative experiences, there's a lot of research that shows that you're not going to come in immediately presuming trust. I was mentioning earlier the office, the V signals, which is part of the Veterans Experience Office, is giving us the opportunity to address issues that people raise with us in something close to real time, not literally that instant, but, and I will say that a lot of our network and facility leaders have been surprised. Not particularly related to minority issues, but areas where they thought things were working pretty well. The veteran said, well, actually, no, it's not, and they made changes and so forth. So I can't change how people, no one can change how people think. I do think two things need to happen. One is that we need to act on the information when people share their concerns, and if we don't, that is a failure, because we will lose an opportunity to gain trust. And that's really the most important aspect of what we can do. Having worked in the field of disparities for a number of years before I came to VA, one of the advice when people would say, well, what would you tell patients to do right now? And a lot of it is to speak up and to just say, I'm worried that I'm still having pain, for example, to use your example. And I know you gave me medicine, but it's really not working. Can we talk about other solutions? But if people speak up and we don't hear them, that will not be effective.
Well, we have to create
Yeah.
a culture where it's safe to speak up and say that. And you're right, we can't change how people think, but we can ensure that once a veteran enters a VA space, that it's free of bias.
Yes.
And it's not tolerated. And that has to be left at the door. Oh, I'm sorry.
No, I'm so sorry. I wanted to mention that, while of course my bias is to worry about how veterans are receiving care and the environment of care for them, I think we should also be concerned about VA providers. I understand that in the healthcare system more generally, for healthcare providers being on the receiving end of racist and sexist comments is also a problem. So let's be concerned about the staff and making sure that they also are able to perform their jobs in an environment where they're being treated with dignity and respect.
Yep, thank you for bringing that up, because that's an important component piece of it. So, well, I want to thank you all for being here. I think this is the first time we've had a hearing on minority veterans, I think, in a very, very long time. Having an afternoon hearing is always difficult because there's too many competing circumstances, but it was important, I think, to at least begin to start to have this conversation. I want to continue the conversation. And Dr. Washington, thank you for traveling from LA to here to join us today. I'm surprised I didn't see you on the airplane, because I usually do.
I was looking.
But anyway, I appreciate everyone being here, and I look forward to continuing this conversation through the Subcommittee on Health and also through the Women's Veterans Task Force. So thank you with that, and with that we will adjourn.
Thank you.